Hello everyone, today I'll talk about polyhydramnios, oligohydramnios and malpresentation. So starting with amniotic fluid measurement, there are two major quantities that we measure in relation to amniotic fluid. One is single deepest vertical pocket, also called SDVP, and the second is amniotic fluid index. So SDVP is the vertical dimension of the largest pocket of amniotic fluid. A normal SDVP is 2 to 8 centimeters, and we define oligohydramnios as an SDVP that is less than 2 centimeters and polyhydramnios as SDVP that's more than 8 centimeters. Coming to amniotic fluid index, that is AFI. So what we do is we divide the uterus into 4 quadrants. So you can divide it into a right and left across the linea nigra and above and below the umbilical line. So that's linea nigra and umbilical line, and we divide it into 4 quadrants. And to calculate AFI, the maximum vertical diameter of the 4 quadrants is measured and summed up. So we call oligohydramnios as an AFI that is less than 5 centimeters and polyhydramnios as an AFI that's more than 25 centimeters. So coming to oligohydramnios, so for that the AFI of less than 5 centimeters or a single deepest vertical pocket less than 2 centimeters is defined as oligohydramnios. On examination, the uterine size will be less than that expected for the gestational age. So there are various causes for oligohydramnios. The first is placental insufficiency due to causes like hypertension, preeclampsia, and collagen vascular disease in the mother. So what happens is that in placental insufficiency, there is reduced blood flow to the fetus. And in the fetus, the blood is therefore preferentially shunted to the brain, that is the organ that requires more blood, and less is given to the kidneys. So because of less blood flow to the kidneys, there is a reduced GFR that leads to reduced urine production by the fetus. Since urine is what contributes to the amniotic fluid, a reduced urine production leads to oligohydramnios, that's reduced amniotic fluid. Then the second is causes like abruptio placentae. Then maternal drugs like NSAIDs, diuretics, and ACE inhibitors. So what happens in NSAID is that NSAIDs can cross the placenta and cause afferent arterial vasoconstriction. This constriction reduces blood flow and GFR in the fetal kidney and reduces urine production. Apart from this, NSAIDs can also cause fetal renal anomalies. ACE inhibitors, their effect is due to two things. So first is a direct effect of ACE inhibitors on the fetal renin, angiotensin, aldosterone system, and this reduces the GFR. And the second effect is because of maternal hypotension. Maternal hypotension can lead to reduced blood flow to the placenta, and that can lead to an oligohydramnios. Apart from this, ACE inhibitors can also cause renal tubular dysgenesis in the fetus. Other causes are fetal renal anomalies like bilateral renal agenesis and posterior urethral valve that results in reduced urine output, and various congenital anomalies as well as infections and torch infections can all lead to oligohydramnios. Certain complications of oligohydramnios are preterm delivery, meconium aspiration, and umbilical cord compression. Coming to management, so in case of oligohydramnios, we have to do a fetal non-stress test and assessment of the single deepest vertical pocket once or twice a week. Maternal hydration is very important, and in case of severe oligohydramnios that is not getting corrected with maternal hydration, we'll go for amnio infusion. So that is with oligohydramnios. Coming to polyhydramnios. Polyhydramnios is defined as an AFI that's more than 24 centimeters or a single deepest vertical pocket more than 8 centimeters. Severe polyhydramnios is AFI that's more than 35 centimeters or SDVP that's more than 16 centimeters. In very severe cases, the clinical features in the mother are also more pronounced. Causes of polyhydramnios includes any cause where the fetus is unable to swallow amniotic fluid, like esophageal atresia, duodenal atresia, anencephaly because of the absence of the swallowing center in the brain. Also, certain neuromuscular disorders like myotonic dystrophy also makes it difficult for the fetus to swallow the amniotic fluid, leading to polyhydramnios. Then there is another interesting syndrome, that's Barter syndrome, which is also associated with polyhydramnios, because Barter syndrome is very much like loop diuretics, and the diuretic effect of this condition leads to polyuria, therefore leading to polyhydramnios. Also, high cardiac output states like supraventricular tachycardia and anemia. So, in cases of high cardiac output, there is going to be polyuria because of increased renal blood flow, and this is seen in severe anemia like alloimmunization or infection with parvovirus B19 or arteriovenous shunting. Other causes include macrosomia, multiple gestations, and gestational diabetes. Gestational diabetes is a very important cause. So, maternal hyperglycemia leads to fetal hyperglycemia and fetal glucosuria, and this leads to an osmotic diuresis and polyuria. This leads to polyhydramnios. And you can also see polyhydramnios in monochorionic diamniotic twins, wherein there's twin-twin transfusion syndrome, which leads to polyhydramnios in the twin receiving the blood and oligohydramnios in the donor twin. And of course, there are also idiopathic causes for polyhydramnios. So, coming to complications of polyhydramnios, it can lead to severe maternal respiratory compromise, malpresentations, because the high amount of fluid makes it very easy for the fetus to shift position. Then cord prolapse, preterm labor, and premature rupture of membranes. And also, because of the uterine distension caused by excess fluid, it can lead to postpartum uterine atony, which can lead to postpartum hemorrhage. Coming to the management of polyhydramnios, so the first thing to do is to assess the symptoms in the patient and how severe is the polyhydramnios. If a severe polyhydramnios is when the AFI is more than 35 centimeter or the SDVP is more than 16 centimeters. And severe symptoms in such patients are a very severe shortness of breath or severe abdominal discomfort or uterine irritability. If these cases are not there, if the patients are just asymptomatic or they do not have severe polyhydramnios, we do not go for any type of intervention because pregnancy outcomes will not be very much affected. But in case of severe polyhydramnios causing severe symptoms such as these to the mother, then we will go for amnio reduction. Amnio reduction basically is inserting a needle to remove some amount of amniotic fluid in order to reduce these symptoms in the mother and improve maternal comfort. So after amnio reduction, we'll check if the symptoms are refractory. If it is not, we can just continue with expectant management. But in case of refractory symptoms, our next steps would depend on the gestational age. A gestational age that is less than 34 weeks, you could repeat amnio reduction. Or if it is less than 32 weeks, we can give indomethacin. Indomethacin has a tocolytic action. It will reduce the uterine irritability and therefore help prolong the pregnancy. And if it is between 32 to 34 weeks, we do not use indomethacin for tocolysis. We can use another agent like calcium channel blockers like nifedipine. Now, if the gestational age is more than equal to 34 weeks with refractory symptoms of polyhydramnios, we could consider for a possible preterm delivery. Now, suppose the mother does not have severe symptoms of polyhydramnios. Basically, the management would depend on whether it's preterm labor or not. So if it is preterm labor, we manage that preterm labor. Otherwise, we'll just go for expectant management. So that is with management of polyhydramnios. So our next topic in this session is going to be malpresentation. So malpresentation, before we go on into the different types, let's first go through three important definitions. The first is lie. The lie basically describes the long axis of the fetus in relation to the long axis of the uterus. So the lie could either be a transverse lie, oblique lie, or a parallel lie. Parallel is when the fetus is in line with the long axis of the uterus. Now, presentation denotes the fetal part that overlies the pelvic inlet. So that could be the head, that is a cephalic presentation. It could be the buttocks, in which case it's the breech presentation. It could be shoulder, or it could even be the umbilical cord. In that case, it's called the fundic presentation. And position is the relationship of that presenting part to the maternal pelvis. So it could be a left occipito-anterior position, which is the most common and most favorable position for delivery. It could be right occipito-anterior, etc. So these are three important definitions of before we move on into malpresentation. So now before we go on to transverse lie, it's important to know that fetal position is determined by gravity and how comfortable the fetus is moving in the uterus. So in early pregnancy, the volume of amniotic fluid is high and the fetus is less constrained in the uterus, so it can take up various different positions. And in some cases, initially in the initial parts of pregnancy, they need not be in cephalic presentation. But as pregnancy advances and the amniotic fluid volume reduces towards term, the fetus takes up a cephalic presentation, the longitudinal lie, because it is in this position that the maximum volume with the buttocks and the thighs are in the fundus, and the head occupies the pelvic region, the lower part. And the longitudinal lie is along the line of gravity, and this is what provides the least resistance to movement of the fetus. Now, coming to the first type of malpresentation, that is transverse lie. So, transverse lie is when the fetal axis is perpendicular to the long axis of the uterus. So, this is the long axis of the uterus. When the fetal axis is perpendicular to it, it's called transverse lie. And most of the time, on palpating the uterus, you'll find that the fetal head is not palpated above the pubic symphysis. Instead, it is palpated at the flanks. And you can confirm this with an ultrasound. And the risk factors for transverse lie include cases like multiparity, placenta previa, contracted pelvis where essentially the fetal head is not able to fit in the pelvis, then uterine anomalies and multiple pregnancies. And a transverse lie can lead to various complications like umbilical cord prolapse, prematurity, fetal trauma, and prolonged labor, which in the end could lead to uterine rupture. Now, that is mostly seen in developing countries, whereas developed countries would have complications like cord prolapse, prematurity. Now, how do you manage transverse lie? Transverse lie, usually the natural history is that these are mostly unstable and most of them would convert into a cephalic or a breech presentation by term. So if it's an uncomplicated pregnancy, you can wait until term or 37 weeks. If it is still in transverse lie, we can try an external cephalic version, ECV, at 37 weeks. And if after ECV also there is a recurrence of transverse lie, you can re-attempt ECV at 38 to 39 weeks. After that, you have one of two outcomes. It could either be a successful ECV, in which case you can induce labor. Now, after a successful ECV, we prefer to induce labor rather than wait for natural labor to progress, because there could be a high rate of conversion back into a transverse lie after ECV. So we prefer to do induction. And if ECV is unsuccessful, we'll go for cesarean section at 39 weeks of gestation. And if the patient is already in active labor, already there are uterine contractions, cervical dilation, or if there's rupture of membranes, then we'll directly go for a cesarean section without an ECV. So that was with transverse lie. Coming to breech presentation. So the types of breech presentation, you have three main types. That's frank, complete, and incomplete. We'll look at the pictures in the next slide. And on examination, you'll find that the fetal head is palpated as a hard mass at the fundus, and on digital cervical examination, you will find a lack of a presenting part. So these are the examples for the various types of breech. So first is a complete breech, wherein there is hip flexion and also knee flexion. Incomplete breech is when one limb is flexed both at the hips and the knee, but the other one is extended at the knee. And frank breech is the hips are flexed and the knees are extended. So these are three major types of breech. Now coming to the risk factors. And before that, in a frank or a complete breech presentation, so frank or a complete breech presentation, both the thighs and the trunk essentially pass through the pelvic outlet at the same time. So if the thighs and trunk completely pass through, the chances of the shoulder and the head to pass through that pelvic outlet is high, although complications can still exist. But if you look at an incomplete breech, it is possible that a single foot or the leg, which is much smaller, can literally pass through very easily through an incompletely dilated cervix. So this makes it a very difficult delivery for the shoulder and the head, because at that time the cervix may not be fully dilated when that single foot or the leg delivers. So that is one complication that you can expect with an incomplete breech. So coming to risk factors. Risk factors include advanced maternal age, uterine anomalies, placenta previa, multiparity, leiomyomas taking up space, not giving space for proper presentation of the fetus, fetal anomalies, and as we already discussed, oligohydramnios or polyhydramnios. And also, it's important to know that the risk for recurrence of breech is also high and increases with increased number of previous breech presentations. So next, coming to management of breech delivery, and as we already mentioned in other malpresentations, a spontaneous version from breech to a cephalic presentation is likely with advancement of pregnancy. So options are, you can wait until 37 weeks and you can perform, if the breech is not converted to cephalic, you can perform an ECV before labor. If it is successful, continue with a vaginal delivery. Second option, ECV before labor. If unsuccessful, you can either do a cesarean delivery or you can go for a trial of labor for vaginal breech delivery. Now this is a bit complicated and this should be reserved for women who have very uncomplicated pregnancies. So those are the first three options. You could also do a direct cesarean delivery without a trial of ECV at all, or an option that's not generally considered is a direct vaginal breech delivery without attempting an ECV. So these are the various options for management of breech. And coming to a little more about ECV, that's external cephalic version. External cephalic version, as we've already mentioned, is done for a breech or a transverse lie if you want to convert it into a cephalic presentation. And this has to be done only at or after 37 weeks of gestation. And after you do an external cephalic version, if the woman is Rh negative, it's important to give an post-procedure anti-D immune globulin to Rh negative patients. Now there are a few absolute contraindications to external cephalic version. These are basically contraindications to vaginal delivery, like a prior classic cesarean section, a prior myomectomy, and a present placenta previa, which prevents a normal vaginal delivery to occur. So that is all for today's video. Thank you, and I hope you enjoyed it.